Hello and welcome to the Pediatric Network. Now today we're going to be talking about neurodevelopment within the neonatal ICU. What does it take to get optimum neurodevelopment for babies that find themselves starting off life in the neonatal ICU? So to be able to talk our way through this, we're going to be speaking with Dr. Welma Lubbe. Now she is the founder and owner of Little Steps. She's a registered nurse and advanced midwife by profession. She holds qualifications in advanced midwifery and neonatal nursing science, general nursing, psychiatric nursing, community nursing, and nursing education. Dr. Lubbe currently holds a position as senior lecturer at the Northwest University Potchefstroom campus at the School of Nursing Science. So we're going to be talking about how to get that optimal neurodevelopment in the confines of the neonatal ICU, but Doc is also going to talk us through what parents should know to be able to move that child from the NICU into their home and still keep that fantastic optimal neurodevelopment going. So without further ado, Dr. Welma Lubbe. Hello and welcome to the Pediatric Network. My name is Mike. I'm your chiropractor and host here for all pediatric content. And today we are very lucky to have Prof. Welma Lubbe with us. Hi Prof, how are you doing?
Good morning, Mike, and thank you very much for having me. I'm doing great. Thank you for asking.
Wonderful. So I'm trying to fight off the cold. Prof hasn't been outdoors yet, which we can see because she's looking nice and fresh and happy. I have just been freezing my bum off outside. So we're going to, hopefully it's kick-started my brain a little bit. So today, what we want to talk about is neurodevelopment, but specifically, we want to talk about neurodevelopment in terms of a neonatal ICU. And how that can happen and how we can affect that better. So I want to start off, Prof, just by asking you, what are we talking about when we use that term neurodevelopment?
So if we talk about neurodevelopment in the ICU or in preterm babies or neonates, it's really about preventing the stress that they experience in the neonatal ICU. So the ICU is really the best place for them to be when they arrive early. So we need to care for them there, and the technology and the pharmacological changes and things improved so much over the last few years. But together with that, the survival rate also improved. But what did not necessarily improve is the correlation with their development at the same time. So neurodevelopment in the ICU is about preventing stress in the baby, but also optimizing their development whenever they are mature enough for that.
Okay. So it's very interesting what you say there, because you almost like your hierarchy of needs. So we started off by going, we need to keep them alive. And then those stats started getting better. And then you start going, hang on a second, neurodevelopment at that time, and especially in a preemie's life, is almost like we talk about those golden hours and those golden days and those golden months where you get those 1,000 minutes and 1,000 seconds. It's and for preemies, I'm guessing that's doubly important.
Absolutely, because we build their brains while they're still in the ICU. Because remember, they should have been in the womb, in utero. And in utero, there's a lot of protection happening. So maybe if we can just have a quick look at what's happening in utero, this is what we see. So in the womb, there's controlled light and sound. There's diurnal rhythms. The temperature is very constant. The baby can grow symmetrically, or the fetus. Nutrition is almost perfect in most of the cases. It's really a small amount of babies that don't get the nutrition that they need. But very important as well, that intrauterine environment provides boundaries for the baby, and that provides tactile and vestibular input, and it provides physiological flexion. And physiological flexion helps these babies with better breathing, better heart rate. Their oxygen saturation is also better. And it also supports them with calming behavior. So if we look at this picture, it's really what we are aiming at when we have this baby in the ICU. Because they should have been in the womb, we try and put them in an environment that's similar to the womb environment. So the hands close to the face, the legs nicely tucked in, and the boundaries that the baby has. So what happens in the womb is the baby really develops in a sensory sequence, starting with touch at about 8 weeks of pregnancy, and touch then also include pain and temperature. And then just for insight, if you have a cleft lip or palate, that develops also at 8 weeks. So before the mom even know that she's pregnant, she will already have all this development happening in this baby. And then it moves on to the movement sense, and then to taste. And with taste and smell, it's interesting. Whatever mom had for lunch or for supper, or if you have your cup of coffee and you like that in your pregnancy, if you smell that, just like that, if you smell that, it gets absorbed by the mucous membrane, moves into the bloodstream, crosses the placenta, and then move into the amniotic fluid. And the baby basically drink what mom had for lunch or for supper.
Wow.
So that way they learn different tastes and smells. And this is very important because after birth, in a full term as well as a preterm baby, we use these techniques that the baby use to help them to calm down and to relax and to self-regulate.
Yeah.
So that happens up until about 24 weeks. Then this smell and taste is fully developed. And then it goes on to the auditory system. Also at 24 weeks, the cochlea and everything is developed, but that input is not quite structured and synchronized at this stage. So just to give you an idea, if a baby is in the womb, they hear sounds differently than they would when they are outside. So to give you an idea, if you say the phrase, "Good morning, it's a lovely day today," and we repeat that by closing your ears, and you say, "Good morning, it's a lovely day today," you will hear there's quite a difference in your voice and how you hear that. Now, the second time around, it's like when you are submerged underwater, and this is how the baby hears it in utero. So now you can see if the baby is 6 months in utero, they hear this soft, muffled sounds, mom's heart rate, the movement of the gut, the flow of the blood in the veins. But now they're exposed to the NICU, and it's the loud noises, and it's loud sounds, and it's bright lights. So this poor baby just go haywire. And why this is important is because they would have built some neurological structures in the brain based on the environment in utero. But now, because they are outside, they built different brain structures. And the whole structure of the brain changes. And that can cause a lot of problems on development, and specifically on a sensory level for these babies.
Wow.
And then the last system to develop is the visual system. So up until 8 months of pregnancy, the iris is gone constrict. So if this baby now comes out and they're in this bright light environment, they can't protect themselves from additional light. And this is very painful for them. But apart from the pain, it can also cause desaturation. And remember, their brains are very soft and pliable at this stage. So desaturation means that they don't get enough oxygen and glucose to the brain, but they have an autoregulation. So they will, in order to get more oxygen to the brain, they will send more blood to the brain. But the vessels in the brain, the capillary vessels, are so small and so tiny and so fragile that they actually burst. So in order to help themselves, they're actually doing damage to themselves. And that causes then the brain bleeds that we see in these babies.
Sure.
So the environment is just extremely important for these babies, and that's why we really build the brains while they're in the ICU.
That's fascinating. The one thing that really caught me was the fact that being outside the womb, the brain structures grow differently. So,
yes.
And then it's up to the environment to almost keep it as, not as similar, but give it as much as it was looking to have to be able to get that
yes.
optimum growth.
Absolutely. And you said earlier, our first aim was to get these babies to survive and then look at the development. And I think that's really changing, and that's why we talk about developmental care in the ICU. So not what's happening in the ICU only, but already what's happening at birth. So even though this baby is tiny, instead of taking it out of the womb and taking it to an incubator and moving it down the corridor, what can we do to keep mum and baby, or dad and baby if mum is not conscious, together in that time period? Because that togetherness already helped with that brain building. And that's why we are so fond of doing skin-to-skin care. And skin-to-skin care can be done at birth. The baby can actually be resuscitated on the mother's chest. That will keep the baby warm. It will help the baby to stabilize and normalize the vital signs. And that's just the best place for the baby to be. But it's very new to clinicians, and it's something that needs to be taught and learned and practiced.
Yeah, I remember sitting in a lecture, I think it was a year or two ago, with Nils Bergman, where he was talking about this, and he was, and I'd understood it to a certain degree before I sat in with his lecture, and then when I left there, I was like, okay, this really needs to get moved more far and wider and have more understanding, because the science behind it is amazing. And that hormonal storm that you create, what it does for baby brain building, even what it does for parents, in terms of having them on. That was one of the things I didn't think about in terms of the benefit to the parent of skin to skin was huge. So the fact that it's
Absolutely, it's so important.
yeah, and the fact that it's growing is wonderful. That actually brings us to a really important point. How do parents then fit into this model of neurodevelopment? What can we do to be able to, explain to the parents, to tell them, to be able to help them, almost give them more efficacy to be able to baby brain build?
Yes. I think that the role of the parent is critically important, and that's really where my career in neurodevelopment started. I was working in the neonatal ICU, and I was sitting next to the bed, and I realized as healthcare professionals, we take over the care of this baby, and we become the primary caregiver, and the parent is really on the side. And then one bright morning, we decide this baby is mature enough to go home. And we phone up the parents and we tell them, your baby can go home at 12 o'clock today. Be here before 12, otherwise you pay another day in the hospital. But be ready and take your baby home. And then these poor parents need to take this baby home, but they never cared for this baby. So we're really moving towards a place where discharge support starts at admission. And that's really what my focus is in life at this stage. So we've developed the website Little Steps, and there's also now a parenting online program where parents can really get the information while they're still in the ICU. Now, what does this entail? It entails a lot of information about just understanding the background of fetal development, like I've explained just now, but also some other things, and maybe I can share one or two slides about that, because I think also the healthcare professionals will find it very valuable. So parents really need to be interacting with their babies. That's the important part. And they need to be able to read the baby's stress cues, but they also need to be the ones that can calm and consolidate the baby, because that's their parenting role. You need to have that bond and interact. Yeah. So some ways that the baby used to self-regulate include non-nutritive sucking. That can be a pacifier, it can be on your finger, mom's finger, the baby's own finger, it can be on the breast. So the parents need to understand what is non-nutritive sucking, what's the role thereof, and how can a parent actually implement that. Now, staff is usually very busy. So if there's a dummy next to the bed, they will use that. If it's not there, they'll make another plan. But the parent can decide which dummy is the best one for my baby. So we provide guidelines for them and where to get the right products. But that said, products is not the main thing that's important in premature care. It's really looking at bonding and getting to that point where we can get to that fetal environment in whichever way you do it. Absolutely. Then just looking at the baby's whole environment. So the staff, maybe there's a new staff member or somebody that's an agency sister and the baby's not positioned well. So the parent can do that positioning and get the baby in the right position. The hands to the chin, which then will support feeding in a later stage because it helps with that bringing the baby to the midline. Hands to the face, providing the baby with opportunities to grasp, like the finger grasping. Just something interesting which I always explain to the parents. Remember the baby in the womb, they had the umbilical cord to grasp onto their own body, their fingers, but boys had extra toys. And that they don't necessarily have outside. They can't reach. But that said, it's very important what we give the baby to grasp on. Because oftentimes the dad will put his hand in the baby's hand, or his finger in the baby's hand, and the baby will pull away. But that's because the baby experienced that as something strange, and they need to protect themselves against anything that's potentially harmful. So we need to understand that there's a delay in the response of the baby. So you need to provide a little bit of pressure, hold the finger there for 10 seconds or so, and then the baby will only grasp. If they have that thing of they draw away. So First of all, the parents need to understand their baby. That's a very important situation. They need to be able to read stress cues. The staff need to do this as well, but the parent is just there, so they can observe this much more. So extension of the extremities, arching, toes playing, the toes and the fingers that go out, sitting on air, the stretching of that whole body. Now, at this point, the staff usually don't have the time to calm the baby down and get them back to this flexed fetal position, but the parent does. So if the baby is highly ventilated, a lot of tubes and things, and you can't skin to skin at that stage for whatever reason, you can do a nice positive touch when the baby is in the incubator. Like you see here on the containment hold, for example. That big hands of the dad is ideal to help this baby to go back into that flexed position in that physiological flexion. Or then do the skin to skin. That would be the ideal way to go about. So, and even if there's procedures, then it would be the parents that actually hold that baby and calm that baby while the staff is drawing the blood or putting in a new tube or things like that. And that combination helps the baby to experience much, much less stress, which is what we are aiming at the end of the day. We don't want stress in these babies. So the role of the parent is really huge. Understanding, looking at stress cues, but also looking what's working for my baby, and then be there to do skin to skin, to change the nappy, to calm the baby when they are not calm. The parent and the baby is a dyad. They should be kept together. In our country, we don't have a lot of hospitals where there's a parent bed in the NICU. In other countries, we actually have a sofa that's like a sleeper couch. So the parents can be there in the day, and at nighttime they can put that down and they can actually sleep next to their baby's bed. And that's the ideal that we want. The difficulty is if there's other babies or children at home, or if they stay far away or things like that, but we can really work around that. And of course, COVID also made it very difficult. Yes. And we have two schools. We have the school of protecting the baby at all cost and breaking that connection between mum and baby, and the school that say zero separation is very important. It's more important than the possibility of getting the infection. So how are we going to go about? Me personally, I go with a school of zero separation, and we need to think creatively. In a difficult situation, how do we keep parents and babies together? Because that's the optimal brain building context that we have.
There's one picture as you were speaking that really came to mind. That was a professional photographer in the States that took a picture now of a baby being born, where the baby is there's a whole plastic screen between the baby and the mom, and they call it first kiss, and this baby is the whole head is in plastic trying to get towards the mom, and you kind of go, what's going on, you know, in the context of the photos. Look how beautiful this is, and there's a big part of me going, okay. It's it's really a mind flip, you know.
Yes. Now I feel your pain definitely, because we're intervening so much that we disregard the normal things, even a normal full-term birth, or in a cesarean section when we need that. We need to be working clean and surgically and prevent infection and so on, but we really go overboard to that part, and we forget the human that we are working with and that dyad. So with my first child, I had this fight with the hospital in having my baby in skin to skin, because I had to have a cesarean section because of placenta previa. So I really wanted my baby in skin to skin in theatre. And it was such a fight to get to that point. It was so exhausting. And that shouldn't be that way. It should be the norm that your baby is born, we do delayed cord clamping, whether you're prem or full term, it doesn't matter. And then the baby go in skin to skin with the mum, suture the mum, and two of you go off to either the ICU or the postnatal ward. But it's a mindset change, especially with professionals that's been working in that context for quite a long time.
Yeah. Do you find that something that is being moved towards at the moment?
It is, but slowly. So it really depends on who's working in the hospitals and in the units, whether they did receive some training on developmental care, and whether that light bulb went on and they saw that this is natural, this is the way it should be. And with natural, I don't necessarily mean have a birth in the river or whatever. If that's your choice, that's great. But I'm not going that direction. I'm just going with not interfering medically if it's not really, really necessary. And if we have to interfere, how can we normalize that as much as possible? Because the science tells us if we normalize it, we build the brains, we build the bonding, we build a healthy society. And that's really what we're aiming at.
I'm guessing there has to be buy-in from a lot of different parties in that hospital setting for that to be effective and for it to become.
Absolutely. Yeah, that's true. And usually the unit manager plays a huge role. Your pediatricians, if you have a strong pediatrician, and then don't forget the gynecologist. They're there first. So actually they should be the one that says, this is how I do a Caesar from now on, or this is how I assist with a birth from now on. And then when the allies come in, currently, especially in the private sector, you need to fight to get in and you need to get a referral, and it's this whole difficult process. Where in the public sector, I actually find it much easier because the allied can drive a lot of things and they can say, well, we need to go into the unit. They speak to the unit manager or the PED, and they can go in for an initial assessment, and in that way they build the whole thing. But in private, it is much more difficult because who's going to pay the bill? Yeah. And I think if we can move past that and say, how do we improve the care of the baby? See them for free maybe in the ICU, but you get them for follow-up. That's one of the models, or the hospital actually providing that service, or the medical aid. So unfortunately, we need to think money because all of us need to eat as well. Yeah. But the bottom line is, what is the best that we can do for the baby and the parent? And how can we do that in different contexts?
Got to try and strike that balance, but it has to be viable to be able to get by. And at the end of the day, we want to get the best outcome for the baby because that's the idea of everything that's being done. So that's, and I think the great thing is as well, and I speak from my perspective, probably me 3 or 4 years ago, where I hadn't taken a deep dive into the research in terms of bonding, in terms of skin to skin, in terms of early neurodevelopment, and then what that gave you later on in terms of related development. And I think talking to that person, you really want to say, look, the info is there. The science is there. It's not it's not what it maybe 10, 15 years ago where we were kind of going, well, we think it's a good idea. It is a good idea, and it has far-reaching consequences.
Yes, and I think really where I see the difference and the change happening is when other people attend some training and we work with real babies and show videos and so on, or when I have the opportunity to work in the hospital with the staff, usually my students, but sometimes with my research project, for example, we identify hospitals that want to implement. So we can go in and we can do some training, and I can actually, when that baby is born and they're very stressed and you have this arching and everything, you can show them physically. Okay, put your hands like this, do this activity, exhale, blah, blah, blah. And they can see, oh, this make a change. And now the baby doesn't crash. So I save this amount of time by putting this intervention in place. That did take me some time, but in the long run, what the difference is. But it's really something, it's an aha moment and a light bulb moment that need to happen before you really implement that. But we need to get to that point where it's a standard of care, so that we don't need so many aha moments, that it's actually just the way that we are trained.
Can we not just aha all at once, and then we can move?
That would be great.
That's the point of something like this. You know, on the network that we're trying to build here, we've got so many different disciplines. And if we can get a message like this through to people on so many different platforms, and even if this can be a springboard for people going, oh, maybe I'll look a little bit further into it, or maybe, you know, these were things that I wasn't thinking about. That's the idea of having someone with your kind of information on, to be able to spark that.
Yeah, we hope that will happen, really.
That's the way. And also, you were saying just now that you do have that course for parents. I'm going to put a link to that because I think as professionals and we're dealing with these people, I think it's very important that as much as, and that's what I've found, is as much information as you give people once they're sitting in front of you, they like 30% sinks in and 70% bounces off because they've got so much. And also they haven't got to that stage yet. And if you can get a resource that when they get to that stage, they go, what did she talk about? Oh, wait, it's on the thing and I can just go and have a look. So I think that's super, super important. And I'll definitely post that. So as professionals here, if we want to give extra backup to those parents, a piece of work like that's super, super important.
Great, thank you very much.
We'll do that. So, Prof, thank you so much for your time this morning. I'm sure I will bug you again because, as we spoke before, Prof has so much more to be able to talk on as well, and so much more fantastic information. So, we'll definitely get hold of you again. But in terms of neurodevelopment within the neonatal ICU, and then having parents being able to buy into still doing baby brain development, I think this is a wonderful springboard. So, I thank you very, very much for your time.
Thank you, and thanks for the opportunity. I really enjoyed talking with you. And have a lovely warm day.
Yeah, I bet. Good.